Right. So, welcome all again.
Good evening, everyone.
Yes, welcome all again. We are again live with Dr. Prakash C. Malshe sir and with another exciting session as we are in the discussion and we are in the journey of understanding about pain management. So, thank you so much again, Dr. Malshe sir, for joining us today. As we all know, he is one of the leading practitioner as far as Haridwar and that part of Uttarakhand is concerned. From his busy schedule weekly, Malse sir is pulling some time for all of us. He is creating and uploading very knowledgeable videos, which I request all of you to watch. Please watch completely all the videos. उनको देखें, वीडियोस को वॉच करें, उनको समझें. सर का जो प्रैक्टिकल एक्सपीरियंस है ऑफ मोर देन 3 डिकेड्स, आई थिंक उसका एक समराइज्ड वे में सर ने कोशिश करा है सारे सेशंस में इंक्लूड करने का. सो डेफिनेटली आपकी क्लिनिकल प्रैक्टिस में all of you will be benefited a lot. So I request all of you to do watch those videos, and on basis of those videos we are doing all these online query sessions at Indian Vadyas. You can go to Dr. Prakash C. Malse YouTube channel on YouTube. Just type the name which is displayed on the screen right now, Dr. Prakash C. Malshe. Just type this name on YouTube. You will get the YouTube channel of Dr. Malse sir. Please subscribe that channel, and continuously sir is uploading several videos. इसी पॉइंट से आज हम चेस्ट पेन के ऊपर फोकस करके डिस्कशन करेंगे, एंड चेस्ट पेन के ऊपर वी विल बी डूइंग आवर टॉक. So, sir, your introductory remark on this topic of chest pain before we'll start taking the questions. I think there are some technical issues, so sir will be joining again. Just give us some time. So just give us a few minutes. Sir will be joining again. Meanwhile, I request all of you to uh, watch a very important session we did on medical cannabis 2 days back. That is available on Facebook as well as on YouTube on our channel. A very important session we have done. So please do watch that. It's a eye-opening session for all of us. How medical cannabis is positioned in India right now, how we all can practice and implement in our clinics. We'll be very soon launching more sessions and more training aspects on that domain. So meanwhile, let me just check if Dr. Malse sir is having any issue. Uh, just give me a second. So there is some technical issue. We'll be getting again him soon, as far as Dr. Malse sir is concerned. So he's just trying to join in again. Let's wait for a minute, and he will be back with us. And meanwhile, as I said, please do watch uh, the previous session. We are getting requests from various doctors and audience who are not able to join. You can see the entire recording in our Facebook as well as YouTube channel. मेरी आप सबसे रिक्वेस्ट है, अगर आपका कोई भी सेशन मिस हो जाता है, यू आर नॉट एबल टू सी, ऑल द सेशंस आर ऑटोमेटिकली बीइंग रिकॉर्डेड ऑन फेसबुक एज वेल एज यूट्यूब. सो प्लीज़ आपको जैसे कंफर्टेबल है आप सेशंस को देख सकते हैं. You can gain the knowledge. You can subscribe our YouTube channel and you can like our Facebook page, so that real time mein you will be getting the notifications of all the sessions going on at indianvadyas.com, uh, be it on Facebook and on YouTube. So we will be trying to get as maximum sessions as available on both platforms. So do follow us, do share with your friends, seniors and juniors about this platform. Also, one more very important request I want to make to all of you today, as meanwhile Malse sir will join us. Please share your valuable feedback. That is very very important for all of us here to get learning, to get motivation. So please, we are just posting the link. Kindly share your valuable feedback. What exactly you feel about this platform? Any suggestion you want to share? Do let us know, and we'll be very much happy to have your feedback. So kindly share, kindly click this link, and you can please share the feedback to us. Thank you so much. Sir is joining in couple of minutes. There was some network breakdown है sir के end पे. He has connected to another network and he will be joining very soon with us. Please give us a minute more, and Dr. Malse sir will be joining again with us for this session today. Thank you.
Yes.
Right, sir. Thank you so much for joining us today, all of you, and thank you for this patience. And we are sorry for this technical error. So, Dr. Malse sir, we just need your introductory remark on the session today, that is of chest pain specifically. So, आपके introductory remark के साथ we will start, and then we'll be starting the questions.
Yes, Piyush, the problem of chest pain is quite intriguing at times because the doctor is running his clinic. There are 10 patients in the waiting room, one patient is examining, and then suddenly someone comes with a chest pain. and at times it's quite urgent, because you never know which chest pain is just benign and which chest pain is going to be fatal. So you have to leave aside all other patients and attend to the chest pain first. We will be talking regarding how to approach the patient of chest pain, but it is a very important thing that there should be no risk involved, either to the patient or to the doctor also, because if the patient feels that he was ignored, he was not attended well in time, and if something bad happens to him, then there may be a bad scene may be created by the attendants of the patients, and this has uh, happened very commonly. And therefore, in dealing with a patient with a chest pain, one has to be very cautious. So leave aside all other patients and take the patient who has chest pain, take him first, and then how to proceed. Uh, Seeing the age and sex, that you need not ask at that time. Seeing the urgency of the situation, if the patient is sweating, if the patient is fainting, ask him to lie down, put the pulse oximeter in his finger, and just have a look at the pulse rate, the regularity, and the oxygen saturation. And in the meantime, try to call in some assistants who will give a nasal catheter, and intranasal oxygen should be administered. One tablet sublingual isosorbide dinitrate has to be given if you suspect that the pain could be anginal or it could be acute myocardial infarction. And then prepare to give an injection. Don't give an injection urgently, because if something mishap happens after giving the injection, then all the blame may come to the doctor, and therefore we will prefer that before giving any injection, at least if it's possible, ECG should be done. If the ECG is not possible in the clinic, at least watch the pulse rate, regularity, blood pressure, put a stethoscope on the chest, and observe if there are any murmurs, and come to some working diagnosis. And if you still feel that the patient may be suffering from acute anginal attack or acute myocardial infarction, there should be no delay made in referring the patient to an appropriate center where the patient could get uh, adequate care. This is relating with the sudden onset of chest pain. If the chest pain has been there for 2 or 3 days, then you can work in a more relaxed way. Take a complete history, do the complete physical examination, and then proceed. So it depends upon what situation, what urgency the patient has come with. Okay, now if there are any questions from your side or from your audience, then please come forward.
Right, sir. So as you said about like patient coming to our clinic, so what exactly the initial like management, or what exactly the initial aspects we need to take care, and then we can maybe proceed with the further treatment or further first of all diagnosis. So any initial steps or any initial tips you want to give whenever patient is coming at a clinic?
You see, regarding the making of a diagnosis of a case in chest pain, uh, the chest harbors all the systems like the cardiovascular system. You have to take note of the cardia and the vascular, because there is the heart and then there are the great vessels, the aorta, the inferior vena cava, the pulmonary vessels. And apart from cardiovascular system, there is the esophagus, a part of the GIT. And then there are the lungs, the bronchi, the trachea. Then there are the hilar structures, hilar lymph nodes. And chest pain can arise from any one of them. And therefore, to make a diagnosis is not as simple. It requires hard work. Taking history in detail and performing the clinical examination also in great detail gives the clues, and one by one, if you gather the clues, probably a definitive diagnosis could be arrived at even before undertaking any X-ray or ECG or any other investigation. The X-ray, ECG, and investigations are just to support your clinical diagnosis, and you cannot totally depend on all those investigations, because if some working diagnosis has not been made, unnecessary valuable time may be lost in sending the patient to the X-ray department and other investigations. But if you have reached near to the diagnosis, then just perform the confirmatory test so that urgently the treatment can be started. This is true with angina, with acute myocardial infarction, with esophagitis, with a peptic ulcer, with a pancreatitis, and with pulmonary conditions like pneumothorax. We will be discussing all of them. I have uploaded already 2 lectures, and your viewers are advised to go to my YouTube channel and watch them. Those lectures are very important and very informative. But if there are any questions ready, I'm ready to deal with them.
Right, sir. Right. So there is one question from Dr. Ravinder. He is want to ask about the ACS syndrome and what can be the differential diagnose related to that.
ACS syndrome or what it is? Please give the full form.
So, Dr. Ravinder, you can please clarify what exactly you want to ask, so that again we will be coming up on this question. Meanwhile, let me just check, sir. There are some questions on the WhatsApp as well. So there is one question, as there are different regions and different areas, predominantly as we can say that the chest pain is on the left side or chest pain is on the right side. So Dr. Shivika wants to ask that if chest pain is on left side or on right side, how we can differentiate, and as per the location of the chest pain, how we need to proceed as far as our clinical diagnosis is concerned.
You see, it doesn't make a great difference if the chest pain is on the left side or the right side. Any side, the pain could be due to pneumonia. Any side, the pain could be due to originating in the heart. It could be due to acute myocardial infarction or angina, or it could be related with any other structures like the way we described in case of pain in abdomen. It could be originating in the chest, it could be originating in the spine, or it may be related with the nerves, and it could be due to the integumental structures and like herpes zoster. And then the pain could be neurogenic or psychogenic also. So it doesn't really make a difference whether the pain is in the left side or the right side. The differential diagnosis includes all these possibilities.
Right, sir. Right. And we got this clarification from Dr. Ravindra. He wants to ask about acute coronary syndrome, as far
Oh,
as
acute, yes. Acute coronary syndrome is what we are talking about. This is the most important differential diagnosis in a case of chest pain, because acute coronary syndrome can lead to fatality. It can lead to mortality, and if you don't attend them urgently, valuable time is lost. You see, a patient could be in unstable angina, and unstable angina can at any time get converted into acute myocardial infarction. Unstable angina and acute myocardial infarction, both of them can lead to severe fatal arrhythmias, and the arrhythmias can kill a patient within minutes, or the patient may go into a pulmonary edema because of left ventricular failure, and that creates another emergency. And therefore, acute coronary syndromes must be identified at the outset. And if it's possible to get the patient inside, I mean, inpatient, as an inpatient, if you have inpatient facility, then the patient should be put into the inpatient department or possibly in the intensive coronary care unit. If it's not there, then the patient should be timely referred to a higher center where such facilities are available. If required, with an oxygen cylinder. If required, call an ambulance with an oxygen cylinder and shift the patient. And if required, please send one attendant also. Depending upon the urgency, if the pain is sudden, the patient has presented to you, oh, there is a pain for the last 10 minutes or 15 minutes or half an hour, then it is an urgent situation, because the pain is so severe that the patient has to go to a doctor within half an hour. There could be a milder chest pain which the patient could have been tolerating for the last 1 or 2 or 3 days. And if the patient gives a history that the pain has been there for the last 2 3 days, then the situation probably is not so urgent. But if the pain is of short duration, of recent origin, then the situation is urgent. And secondly, if it is accompanied by sweating, by vomiting, or by a fainting sensation, and if on observation you see that there is an irregularity of the pulse, or if it is very fast, or if it is very slow, if there is a great change in the blood pressure, if the blood pressure is very low or very high, all these situations they indicate towards a dangerous possibility.
Sir, the next question is from Dr. Kavita Agarwal, that how the anxiety play a role as far as chest pain is concerned.
It is very important because the chest pain of anxiety is a chronic, dull, aching pain. It can be pointed at by one fingertip. The patient can tell you the pain is precisely over here. And at times, the pain could be due to costochondritis of the costochondral junction, or very often, if it's not there in the costochondral junction, any other point in the muscular chest wall can become painful and tender in patients of anxiety. That is a dull aching pain, and it aggravates whenever the patient faces such a situation which gives rise to anxiety. For example, if someone approaches crowded places, for example, someone approaches his office, which leads to generation of lot of anxiety. For example, if someone encounters guests or goes to a market or whatever the situation may be, whatever situation triggers anxiety, that thing triggers the pain as well. The pain is then associated with a sensation of ghabrahat, as if something is going to happen. What is going to happen, the patient does not know clearly, but then there is something, and which people often describe, जैसे बचपन में किसी की कोई चीज लेके छुपा ली हो. They liken it with the sensation that arises. Supposing you were in a fifth standard, and you steal someone's pencil box and hide it, and then there is a sensation that you may be caught, and uh, then what will happen? So that sensation is a peculiar sensation of anxiety, and that anxiety sensation, whenever is associated with the chest pain, then probably it is the cause of the chest pain as well.
Right, sir. Thank you so much for
Piyush,
this.
in anxiety cases, the ECG may be absolutely normal, or sometimes it may even show changes like T wave inversions, and those T wave inversions can be reversed by just administration of potassium. So you give syrup potassium chloride or a tablet of sustained release potassium chloride to the patient, and after 1 or 2 days or 3 days, repeat the ECG. The ECG becomes normal. You give anxiolytic to the patient or a small dose of beta blocker, and the chest pain also disappears, and the ECG changes also reverse. So these are the signs that the chest pain was due to anxiety.
Right, sir. Thank you so much for this aspect. So we have also seen that in case of chest pain, the mindset should be to get it diagnosed as soon as possible, and certain kind of investigations help us in diagnosing. So what exactly the investigations you suggest as far as whenever we get a case of chest pain? And I also request, meanwhile, all the doctors who are listening to us, you are very welcome to post all your questions quickly and queries. And also, we have shared the detail of Dr. Malse's YouTube channel, so please subscribe that and watch all the detailed video. As I clarify again, this session will only be for the query discussion. For the detailed session, you can watch the videos already available on the YouTube channel of Dr. Malse sir. Right now, you can post your question. So, sir, what investigations you suggest and you guide for a
Well,
chest pain?
before we proceed to investigations, let me again highlight that the simple art of history taking and the simple art of clinical examination, which also involves the general examination, there are a lot of clues to be found just by examining the pulse, just by observing the tongue for cyanosis and the nails and the formation of edema. And if you miss any of these things, then the diagnosis would be missed. Then the use of all those four techniques over the chest, that is inspection, palpation, percussion, and auscultation, and chiefly it's the auscultation which can give you very important clues regarding the diagnosis. The most important and initial investigations are, of course, the ECG and chest X-ray. Of this, ECG machine would be available in most of the clinics of our listeners, and if it's possible, we will also have few lectures on interpretation of the ECG if you will wish. Then, but uh, 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 presently it is enough to say that if there are changes in the ST segment and T waves in the ECG, they point towards involvement of the coronary arteries. That means in coronary arteries, either there is angina which gives rise to ST depression and T wave inversion, or if it is developing an infarct, then there is ST elevation and T wave inversions. In any of these, maybe in angina or an infarct, there could be any of those arrhythmias which are characteristically uh, diagnosed by ECG, and we divide them into tachyarrhythmias and bradyarrhythmias. There could be extrasystoles, there could be atrial tachycardia, there could be atrial fibrillation, or even ventricular ectopic beats or ventricular tachycardia in runs. And sometimes there could be heart blocks like the 2:1 block or Wenke back block, or sometimes the complete heart block. So ECG is a very valuable investigation in diagnosing the coronary artery disease. And secondly, X-ray chest is also very important because, as you will see in my those two uploaded lectures, pneumothorax, pneumonia, pleural effusion, these are very important pulmonary findings which you can come across in an X-ray chest in a case of chest pain. Just by observing the chest wall is very important, because if you miss to observe the skin of the chest, then you may miss the diagnosis of herpes zoster, which is quite a common cause of chest pain. In the last only 2 months of the lockdown period, when I'm offering advice only online, then also I was able to diagnose 2 cases of herpes zoster just by asking the patient to send me the photograph of the part involved. And on the first day, I just spotted very small 2 spots which were red, elevated, and having a few vesicles there. And the herpes zoster was diagnosed, and lot of many investigations and unnecessarily giving medications was saved.
Right, sir. Right. Thank you so much for this aspect. I can see there is a very long question. In fact, I will display, and he is from one of our beloved senior and a very,
Severe
I will
GERD
say,
related
successful.
esophagitis and gastritis and ACS often hard to distinguish, and sometimes ECG is inconclusive. Then how to approach to rule out myocardial infarction? As these days many younger persons are diagnosed acute MI without prior history of any cardiac ailment. Yes, if it is of a
So,
recent onset, if the pain has occurred only today, and if there is sweating, and if there is no other alteration in the pulse rate, BP, anything, and if you still suspect that there should not be any acute coronary syndrome or myocardial infarction, then apart from ECG, you can also refer the patient for echocardiography. And you must also know that there are several markers of cardiac injury which are found in the blood. I mean, if you subject blood test to SGOT, CKMB, creatine kinase, and TROP-T, these are very valuable investigations which will give you a clue that myocardial injury has occurred or not. And if at all myocardial injury has occurred, then the patient needs to be under care of a cardiologist. Equally important is not to miss the diagnosis of pancreatitis, because whenever you feel there is esophagitis or there is a peptic ulcer, and if you give the treatment with antacid, with H2 blocker, with proton pump inhibitors, and if the treatment does not succeed, then it's probably something else. These days, alcoholism is quite common in the youngsters, and alcohol can lead to pancreatitis at any time. To injure the liver, alcohol will take 5 or 10 or 15 years. You don't get cirrhosis of the liver or liver injury very quickly. At times, acute alcoholic hepatitis can occur, but that could be resolved after abstaining from alcohol. But if pancreatitis is triggered, stopping the alcohol will not reverse the pancreatitis. It will require treatment under intensive care. The patient will need hospitalization, intravenous fluid, treatment with antibiotics, and rest to the pancreas by giving rest to the gut. And therefore, the diagnosis of pancreatitis also should be considered and kept in mind always whenever dealing with a case of chest pain.
Right, sir, and thank you so much, Dr. Jayakrishan Pandey. He is a senior, beloved senior, and respected senior, and very successful clinician and practitioner in Uttar Pradesh, Lucknow. Thank you, boss, for joining us today. And Malse, sir, I think you must be remembering him. He is
Yeah,
from
I remember
Bangalore
him very
only.
well. Yes, yes, yes.
So thank you, Dr. Pandey, for joining us today, and thank you for this very interesting question and aspect you have raised. And we all are very motivated and excited to see our senior as successful as like you. Uh, Next question from Dr. Kavita Agarwal. Sometimes patient says tingling sensation in chest, but no pain is there. So how we need to interpret this, sir?
You see, the variants of pain are there. Sometimes the patient complain of burning sensation, and which is rightly interpreted as esophagitis. But I must point out that angina pectoris and acute MI also sometimes present as a burning pain. Regarding the tingling sensation, no book mentions that tingling sensation indicates coronary artery disease, but there is no harm in investigating any patient who comes with tingling sensation in the chest, and you should first rule out the coronary artery disease and then proceed to make a diagnosis. It could be possibly related with the chest wall, or it could be related with the nerves. And many times nowadays what we find is, since the tests for two vitamins became available, we find that several people of the population, they are deficient in vitamin B12 and deficient in vitamin D, and there is all the reason to believe that whenever the tests for other vitamins will become available, you will also find several people who are said to be well fed, they are also found to be deficient in various vitamins. It's not that if you find a certain person deficient in vitamin B12 that you will supplement B12 only. You must supplement all the vitamins. And why to subject even to the tests? You must supplement all the vitamins to all the patients coming with a tingling sensation, maybe in the chest or in the fingers or in the toes or wherever. There is tingling sensation, it could probably relate with the neuropathy. And for the nerves, the vitamin of the B complex factors like the thiamine, the riboflavin, niacinamide, pantothenic acid, and folic acid, and cyanocobalamin, they are very essential for the cellular function. And in particularly the B1, B6, and B12, they are called the neurotropic vitamins, and therefore these must be supplemented in any case wherever the diagnosis is not forthcoming.
Right, sir. And as far as risks are concerned, of chest pain, as you have initially mentioned about certain aspects, we can again maybe have some more insights that what kind of risks are associated and how we need to understand. And in fact, the same question which we have discussed in the I think previous session also, till what time we can manage chest pain in our clinics, at what time we have to refer to a higher center.
If ECG is available, then it becomes somewhat easier. If the ECG is normal, okay, the ECG needs to be repeated after 12 hours and 24 hours. That's a different story. If you have a confidence in your chest examination, you will probably not miss a case of pneumonia, pneumothorax, or acute dry pleuritis or pericarditis as a cause of chest pain. If you are confident about your history taking, probably you will not miss a case of esophagitis or hiatus hernia or peptic ulcer. Regarding pancreatitis, no one can be sure, no one can be confident, and therefore all these entities have to be kept in mind always whenever dealing with chest pain. The dangerous possibilities which can kill the patient are unstable angina, acute myocardial infarction, to tell the cardiovascular causes, in the pulmonary causes, and pneumothorax can kill the patient. And of course, pancreatitis is very dangerous. It could lead to fatality. And these dangerous possibilities must be first excluded before you further treat the patient. If you detect any one of these, then it is best to refer to higher center timely, because the patient would be thankful to you that you referred him very timely. And at times I have even dropped the patient in my own car to the higher center, because if the ambulance takes time in coming, the unnecessarily delay should be avoided, and the patient should get medical relief well in time. That is very important, particularly in cases of chest pain.
So the next question, sir, is while transferring patient to cardiologist, if distance is more, what instructions need to be given to the relatives?
A relative probably cannot handle any situation arising out of cardiac arrhythmias, or say the patient has pancreatitis. Some paramedic should accompany the patient to the hospital, and paramedics are well equipped with a kit of injections and syringe, and the ambulance is well equipped with oxygen cylinder, and therefore it is very safe uh, to shift the patient in an ambulance with a paramedic. If the patient is given continuous oxygen, at least oxygenation is proper and the coronary ischemia is reduced. If the patient gets breathlessness or vomiting and you detect bronchospasm, the patient could be given an injection of bronchodilator at times, or maybe propped up, and the pulmonary edema will be reduced to some extent. Sublingual tablet of isosorbate dinitrate could be given uh, with greater frequency so as to reduce the chest pain. But in most cases, the relatives probably cannot handle the situation, and the paramedic, if one paramedical staff can accompany the patient, that is the best. If a doctor can accompany the patient, that is even better, better than the best.
Right, right. I think Dr. Kavita, you must have got your answer, and thank you so much again for asking these wonderful questions and for supporting us. I request quickly any other doctor wants to ask any other question, do let us know. Sir, we have one more question on our WhatsApp. Just let me. So Dr. Manisha is asking, as far as chest pain is concerned, we sometimes see in kids also we have chest pain. So which what kind of maybe aspects we can estimate or we can consider?
Kids are quite prone to viral infections, and we have seen viral pericarditis, viral myocarditis, and all such infections occurring in kids. And then kids are also quite susceptible to hyperacidity, esophagitis like problems, because if they eat uncontrolled, and whatever they eat, it could lead to formation of hyperacidity or esophagitis. And kids are also quite susceptible to psychological uh, pains, whether pain in abdomen we discussed last time, and also pain in chest. So the clinician has to use the judgment whether the pain is due to any viral infection, because of course in childhood the coronary artery syndromes are not so common. They could probably occur in very rare cases due to either congenital malformations in coronary arteries, or maybe due to some inherited error of metabolism leading to hypercholesterolemia, but of course these are quite rare.
Right, sir. Right, right, sir. Thank you so much for this, and I request all of you to kindly watch certain videos which are available on YouTube channel of Dr. Malse sir for getting more insight on chest pain. Sir, what exactly the topics will be there in the future sessions? Can we just have some insight on that, maybe in the next session?
Next session we may deal with vomiting, because whenever we discussed about pain in abdomen, then also we discussed about vomiting. Or if your viewers prefer, then we will take the other pains like the headache, like the migraine, like
Hello.
but yeah, so any of these topics can be taken, but your viewers vote can be taken, or you yourself could decide whether you want to take up either the vomiting or one of these pains like the headache, like the backache, and the generalized body pains and muscle pains, the way it occurs in fibromyalgia, and the differential diagnosis of these. So whatever you say, please decide right now and tell me so that I can upload a couple of videos. Will you like to have headache?
Yes, sir. Yes, sir. Definitely.
Okay. You don't like to have headache, but you will like to have a discussion on headache.
Right, right. There is one more question from Dr. Pandey, that how much VPS, bigemini and trigemini are considered normal in ECG, and when to advise for higher investigations.
Ventricular premature contractions. A very simple test is there. If a young person is having ventricular premature contractions, give that person a little exercise and then repeat the ECG. If ventricular premature beats disappear by exercising, then they are benign. In other cases, administering a little potassium chloride for a couple of days will also abolish the ventricular premature contractions. Sometimes I have seen people counting their own pulse and detecting that they are having 2 missed beats per minute, or maybe 4 or 5 or even more. So the counting of the pulse and finding out how many missed beats are there is not very important, because all those could be also benign. But if it is leading to anxiety, then of course ECG, Holter monitoring, treadmill testing, and echocardiography and cardiac pulmonary coronary artery angiography. These are all are investigations to reassure the patient that he is not suffering from any dangerous disease like angina or myocardial infarction. At times, you may also try to find out if there are any other risk factors, like if the patient is smoking, the smoking should be stopped. If he is taking excessive coffee or tea or any other beverages, that should be controlled. And if there is hypercholesterolemia, that should be controlled. And with all this, probably the ventricular premature contractions will either abolish, or you may require to give him some antiarrhythmic drug. We will be discussing about the antiarrhythmic drugs in one of these lectures. Regarding the ventricular premature contractions, if they are repeated too frequently, then amiodarone is probably the drug of choice in such cases, about which we will discuss in one of the lectures. You may go and read about the amiodarone, its effects on the cardiac arrhythmias, which arrhythmias it is able to treat. Sukumar Joshi, what do you suggest? Aspirin, clopidogrel, sorbitrate. Yes, it's very important. Aspirin clopidogrel combination is good at preventing any thrombosis anywhere, particularly the coronary thrombosis and particularly the cerebral thrombosis. And this combination has to be used in patients who are having other risk factors like hypertension, like diabetes, like smokers. And if you use this combination, the risk of thrombotic stroke as well as the coronary syndromes is reduced. And you can go and read the statistics about them. But of course, aspirin involves a certain risk of its own, because a patient taking aspirin cannot undergo a dental extraction, and even with trivial injuries they will bleed. There will be accumulation of blood in the subcutaneous place. If there is a joint injury, then the blood can accumulate in the joint. If there is any GIT problem, then aspirin can aggravate the gastrointestinal bleeding. If there is any animal bite, if there is any fracture, then also aspirin can increase the bleeding. And therefore, giving aspirin in a long term, it must be done with caution. The patient also must know what the drug is going to do. Normally, we tell the patient that this drug will thin your blood. This is blood thinning agent, and therefore the patient should be given a correct interpretation of what the blood thinning means. That the blood will not clot, and if you get a certain injury, immediately you should stop the aspirin, because I have seen huge hematomas accumulating under the skin, and then the hematoma got infected, and then the patient had to bear all that trouble of oxygen and dressing daily for months together. In one more case, when the patient was on anticoagulation, he was bitten by a dog, and then also he needed to be given several bottles of blood transfusion, because the blood will not clot, and you cannot stitch a wound caused by the dog bite, because if you stitch the wound and if the patient is under anticoagulation, then the blood accumulates inside the wound and the subcutaneous areas, and it becomes very difficult to manage. And therefore, giving aspirin and clopidogrel in the long run is, of course, advised by cardiologists all over the world, but it needs to be given with caution, and the patient also should know that it involves a certain risk of bleeding from anywhere, from injury sites, from the GIT, from any cuts, bruises, etc. Otherwise, they are very useful drugs. They prevent formation of clots. Even after explaining, patients sometimes don't go to higher centers within time, and afterwards blame us what precautionary measures we should take to save ourselves. Every advice given to the patient should be recorded. It has to be given in writing, and it's best that you keep a copy of that advice with you, keep a copy of the ECG with you, and tell at least some responsible relative of the patient. Once I came across such a situation. There was a patient who came in left ventricular failure. I did his ECG. There was acute myocardial infarction, but he didn't believe. He said, Dr. Saab, I am doing so much of pranayam every day. How can I suffer from an heart attack? I immediately rang up his son, told him that your father has suffered from a heart attack. He doesn't realize it, but he needs to be admitted to the intensive cardiac care unit. And you please take him, don't take him home, take him directly to the hospital. And he was taken to the hospital where he stayed there for about 7 to 8 days, and then he recovered. So, whatever steps are needed at such a time, you need to take. Uh, Inform more people. If the patient is not listening to you, uh, then inform more people, some responsible relatives of the patient, some responsible friend of the patient, and ensure anyhow that the patient reaches the correct place, like an intensive care unit of a hospital. Dr. Jayakrishan Pandey has thanked us. Thank you, Piyush.
Thank you so much, sir, again for your time, and we definitely respect you a lot for taking this initiative. I quickly want to request here to all the doctors who are watching us. Let's give some more support to Dr. Malse sir, and let's share his videos to among our all communities. We all must be having several WhatsApp groups. We all must be having several social media platforms. See, sir is just doing for the sake of spreading knowledge, and we all should propagate and disseminate this to in our community. So मेरी आप सबसे रिक्वेस्ट है कि प्लीज सर के सेक्शन, सर के वीडियोस को ज़्यादा से ज़्यादा शेयर करें, सर के यूट्यूब चैनल को ज़्यादा से ज़्यादा शेयर करें. हम एक डेडिकेटेड पोस्ट अभी बना के आप सबसे शेयर करेंगे, so that you can just share and forward that to all your senior juniors and batchmates. We need to now increase the subscriber list and overall viewership of Dr. Malse sir, because he deserves, and the quality and the level of knowledge he's just giving to all of us free of cost is invaluable. So please support us in this initiative, because that will be the only motivation for us to take it forward. Sir, your final remark on this topic and next topic of the week.
Piyush, what I feel is that these lectures are definitely useful to the practicing clinician, but of course they are very useful to the student group who are in their third year or their final year. And in the last two lectures on chest pain, I have put a very interesting X-ray which shows pneumothorax, and I will advise all of your viewers to just go to my channel and watch those X-rays. In the next lecture, we will deal with the topic of headache, and in the meantime I will also upload at least one or two lectures relating with the topic headache, migraine, and all other such things.
Right, sir. Thank you so much for your time, and thanks all the doctors and students for joining us today. We'll be seeing you next week, same time. Do attend the session, and meanwhile, watch all the videos which are there on Dr. Prakash C. Malse YouTube channel. And please join us again. Have a lovely week ahead. Thank you so much. Take care. Thank you,
Thank you,
sir.
Piyush. Keep it up.